Okay, well, thank you for having me. I'm an anesthesiologist by training and then did subspecialty training in pain medicine at Hopkins and stayed on faculty after I finished that fellowship. And currently I'm the director of the Pain Treatment Center as well as the Pain Fellowship program that we have at Hopkins. And I'm going to talk about interventions that we typically use to try to help treat neuropathic pain. Forgive me if some of what I have here is an overlap from Dr. Lin, but I'll try to go through the slides sort of expeditiously and highlight those aspects that I feel are relevant. So with respect to an overview, I'd like to talk about acute versus chronic pain, nociceptive versus neuropathic pain, some mechanisms behind both of those, and then hit the thrust of the talk, which is interventional strategies or injections that we use to try to help relieve neuropathic pain. So with respect to a classification of pain, I mean, the easiest way that I think about it and that I teach the fellows is that there's acute pain and there's chronic pain. And subsumed under chronic pain would be nociceptive pain, neuropathic pain, visceral pain, and then a mixture of all three of those. And often, in patients, for example, who have low back pain, we do see a mixture of nociceptive and neuropathic pain, and it's often hard to sort out mechanisms that are the source of that particular pain. Well, acute pain is thought of as basically an unpleasant reaction or sensation secondary to some type of tissue damage that might be related to surgery. It might be related to spraining your ankle, for example. It is viewed as normal and protective, and the degree of pain that patients experience typically corresponds to the degree of tissue damage. The outcomes with respect to treating acute pain are pretty good. I mean, typically we use opioids, say intraoperatively and postoperatively, and most of the time patients get better. In chronic pain, however, the situation's a bit different, and the International Association for the Study of Pain classifies or describes chronic pain as pain that persists, in essence, after the expected time that that the tissue heals, and that pain that patients experience is simply out of proportion to anything that you'd pick up clinically. It really doesn't serve, as far as we understand right now, any clinical benefit. And what it does do, unfortunately, is sort of induce a lot of psychosocial difficulties, depression, anxiety, for example, and other comorbidities. The outcomes with respect to treating chronic pain, I said poor, maybe that's a little strong. I should probably say maybe weak treatment outcomes. Although I have to say also that in terms of what I see in our pain clinic, and we see primarily chronic pain patients who have some cancer pain, but primarily benign, non-cancer pain. I mean, the outcomes can be quite good in terms of percent relief and an increase in mobility, an increase in range of motion, and an enhanced quality of life. Nociceptive pain then is thought to result from some thermal or mechanical excitation of nociceptors or the pain receptors. And we, as Dr. Lin mentioned, the nociceptors are typically located throughout the body. So you can think of them as being located in the skin, in the subcutaneous tissue, in the muscles, in the viscera, around the blood vessels as well. And many patients will say that this type of pain, if they're experiencing what we classify as nociceptive pain, they'll say that the pain is typically aching or throbbing, sometimes sharp. And this pain is typically responsive to morphine, fentanyl, Dilaudid. Well, neuropathic pain is quite different, and this is a slide of a patient who has complex regional pain syndrome in her left upper extremity. The definition of neuropathic pain, essentially, as Dr. Lin mentioned, is thought of as some type of a lesion in the central nervous system or the peripheral nervous system or both, and that this type of pain continues despite tissue resolution or basically tissue healing. There are several clinical characteristics that are often associated with neuropathic pain that I listed there. That is, patients will describe burning pain, electric-like sensations, sometimes shooting pain, and maybe a continuous stabbing pain, often describe allodynia or pain in an area that shouldn't be ordinarily painful to a painful stimulus, and sometimes also describe sensory deficits in that affected area. There are multiple origins of neuropathic pain that range from peripheral nerve trauma, entrapment neuropathies, for example, to diabetic neuropathy, infectious causes, chemical causes, chemotherapy-induced neuropathies. We do see that often resolve but sometimes don't. And dorsal, and then spinal cord nerve root injury, we often see, unfortunately, as sometimes a result of surgery or trauma. Postherpetic neuralgia is another classic neuropathic pain state, trigeminal neuralgia, and say arachnoiditis, often we see after patients have had multiple spine surgeries, fusions for example, they'll develop sort of chronic back pain and sometimes leg pain. Prevalence is similar, to Dr. Lin's slide, but the prevalence of neuropathic pain, as you can see, is high in, low back pain has a huge prevalence of neuropathic pain in the United States. It far outweighs other conditions. The thing about low back pain, though, is that the etiology is tremendously hard to establish, and it's also very hard to establish whether patients have low back pain that's nociceptive or neuropathic, and often it's a combination of both of those. The incidence of neuropathic pain is high in patients who have AIDS, in cancer patients, and in patients with diabetes. This is a very similar slide to Dr. Lin, so I think I'll just touch on a couple of points here, and that is that in patients that we see who have neuropathic pain, they often do demonstrate pain due to a stimulus that wouldn't ordinarily be painful, called allodynia, and hyperalgesia, so increased pain in the affected area due to a painful stimulus. But there can be multiple other clinical manifestations of neuropathic pain listed here and in the next slide. Well, neuropathic pain in general is hard to treat, it's hard to diagnose, and really what's hard about it is the fact that we can't really link the symptoms that we see in patients to particular mechanisms. And that's sort of, I think, what the pain community of researchers is trying to establish, because if we can figure out what the mechanisms of the particular type of pain are, then we can target therapies, particular injections, for example, or specifically medications to that mechanism. So in patients, we see sometimes that a single mechanism can lead to multiple symptoms. Or a single symptom can result from multiple mechanisms. On the other hand, we have different mechanisms that may coexist in one patient and in time get worse. The processing that occurs is abnormal and relates to ion channel abnormalities and cytokines and enzymes and basically abnormal communications that exist between large and small fibers. And the mechanisms range from sympathetic dysfunction, sympathetic nervous system dysfunction, to dysfunction in the peripheral nervous system, dysfunction at the level of the spinal cord, specifically the dorsal root ganglion or the dorsal horn, and then to the brain in terms of the thalamus, processing of pain in the thalamus, and processing of pain in the somatosensory cortex. In general, I think we think of sort of this sensitizing soup that's causing neuroinflammation, and I've listed there lots of different stimuli that we think are part of this soup that sensitize pain receptors and over time bombard the nervous system and lead to chronic pain or neuropathic pain states. This is a slide that I think is really useful because it lays out in general what I've just described. So on the left, you see tissue injury, and after tissue injury, there is a release of stimuli. So, histamines released, prostaglandins are released, ATP, hydrogen ion, all released, and basically sensitize the nociceptor, the A delta or C fiber, and that information is transmitted to the spinal cord, to the dorsal horn, and then from there to the brain, where it's interpreted as painful. This is another really, I think, helpful slide that helps me understand maybe the transition between acute pain and chronic pain. On the left represents acute, right is chronic. This structure represents, say, an A delta or C fiber, and this structure represents the dorsal horn of the spinal cord. And so in essence, in acute pain, we see that glutamate is released normally and binds to a receptor. In chronic pain states, what we believe happens now is that there's a bombardment of glutamate against the receptor, the NMDA receptor. That receptor changes conformation and in essence leads to new gene expression. And that C-Fosh gene expression, we believe, sensitizes the dorsal horn cell and leads to this phenomenon called central sensitization, chronic pain and perhaps neuropathic pain. Well, with respect to interventions, this slide says nobody's picking on you. It has I think You can all see it, but if you can't, it's a patient in bed, and there's a huge blanket that looks like a target on him. And there's his friend talking to him saying, "No one's picking on you. The injections are to help you get well. I'm sure the nurses don't enjoy it any more than you do." And I actually put that up there because I think sometimes patients are scared of injections and feel like we're going to poke and prod and really hurt them. Sometimes, rarely, hopefully that happens, most of the time they're surprised at the level of comfort that they receive from a mere injection. So the targets for some of these injections are illustrated on this slide, and they range from a peripheral nerve, so nerve blocks, which are the most obvious, say a sciatic nerve block, an occipital nerve block for occipital head pain, median nerve branch blocks in the spine that can help reduce axial lumbar pain, to the dorsal horn or the spinal cord area, where we might target that area with intrathecal agents, for example, morphine or bupivacaine, or spinal cord stimulation that can help modulate processing at the level of the spinal cord. There are multiple neuropathic pain syndromes. I'd like to talk about two in particular, the postherpetic neuralgia and complex regional pain syndrome, simply because we typically perform more interventions, procedures on those types of patients. And there is some evidence that I'd like to discuss with respect to the efficacy of procedures for these two syndromes. Postherpetic neuralgia is shingles-related pain, and it's caused by herpes zoster. And typically patients experience a rash followed by vesicles. The vesicles then scab, and the pain ensues. A lot of those patients describe pain that's burning and electric-like and sort of horrific, not as bad as the trigeminal neuralgia pain, but sometimes very similar, it seems. And the pain courses along a certain dermatomal distribution, and lasts typically greater than 1 month after the rash heals. Often the chest and the face is affected, although there can be other areas as well. More common in women, and unfortunately, as we all age at this point, we have an increased risk of developing postherpetic neuralgia, as you can see here. So 50% of patients report pain after 1 year if they're 60 years of age, and then it jumps to 75% of patients reporting pain beyond a year at age 75 or over. This is what it looks like. This is someone who has herpes zoster. So this is before it develops into postherpetic neuralgia, but you can see the rash that's in a dermatomal distribution at the thoracic level, and erythema and vesicles, and it's starting to scab up, and it's quite painful. This is a severe case of someone who has herpes zoster in thoracic, maybe upper thoracic dermatomal distribution that actually shows reasonable healing. The vesicles are scabbing up, and it actually sort of looks like a third-degree burn. Well, what is the evidence for the treatments that we use, the injections that we use to try to help treat this condition? There are 4 blocks that we typically use: intrathecal steroid injections, epidural steroid injections, sympathetic blocks, and spinal cord stimulation. Well, intrathecal steroids were studied by Kotani in 2000, and he had a very high sample size of patients who had intractable postherpetic neuralgia for 3 years. It was done fairly well. It was randomized, double-blind, and controlled, and he had various different groups in which he injected lidocaine intrathecally, or lidocaine plus steroid, or basically no intervention at all, no lumbar puncture at all. And he reported, or he didn't report, but the patients reported that there was 90% relief in the group that had the lidocaine plus the steroid. Again, it was injected into the cerebrospinal fluid. They reported good to excellent relief and a decrease in their anti-inflammatory use. And the same patients described the same degree of relief even 2 years later and had no side effects. This is an important study, and unfortunately, most of us actually do not use this intrathecal therapy, that is intrathecal local anesthetic and steroid, to help treat this condition because of other reports and our experience that display possible chemical meningitis, arachnoiditis, and maybe transverse myelitis that can result from repetitive injections of steroid intrathecally. Another author, Kikuchi in '89, studied epidural steroids and intrathecal steroids for postherpetic neuralgia. And unfortunately, some of these studies that we have suffer from low sample size and, maybe have some methodologic problems. Nevertheless, I feel like, they can be used as a springboard for further studies that are larger and that perhaps are of higher quality. And they're helpful also because without them, well, we wouldn't have anything in the literature that would help guide therapy. And most of these studies at least illustrate some positive effects on patients with these chronic pain states. And again, a lot of these patients who suffer from these two disease states and others simply don't respond to one therapy. So it's nice that we have an armamentarium of other therapies to help enhance the quality of their life. Kikuchi then studied just 25 patients, in essence, intrathecal steroid versus epidural steroid, and patients who had PHN greater than a year. It was randomized and controlled and singly blinded. And in essence, he evaluated continuous pain, shooting pain, and allodynia before treatment, end of treatment, a week later, and 24 weeks later, and basically found that there was significant pain relief in the patients who received the intrathecal steroids, like the previous author found, and not much pain relief in those who received the epidural steroids. So the feeling is that patients who have an acute phase, so suffer from acute herpes zoster, typically do benefit from either intrathecal, but typically not done in the United States, and mainly epidural steroids that can help reduce pain in that acute phase because it's felt that the steroid will reduce neuronal inflammation that's associated with acute pain and may somehow stabilize the membrane with respect to C-fiber transmission. I wanted to show you a slide of what we actually do, and this is a basic slide of an epidural steroid injection. Patients essentially lie on their belly, and it can be done with fluoroscopy, with X-ray that is, or without at the bedside. We typically do it with fluoroscopy. And on the left, this is just illustrating the spine. Front view, or this is front, this is back, and the little purple item here is the spinal cord with nerves, and patients lying prone, and we use essentially a fairly small needle that we insert into the L5-1, L4-5 level, inject contrast to outline the epidural space, and then inject usually a little local anesthetic and some steroid, typically methylprednisolone. What about sympathetic blockade in patients who have postherpetic neuralgia? Well, these studies that were done, so typically if patients have, for example, postherpetic neuralgia in the thoracic level, we'll try to do intercostal blocks, maybe an epidural steroid, but the intercostal blocks will also block the sympathetics. If they have postherpetic neuralgia in the face, we might try, I'll show you soon, a block called a stellate ganglion block to try to block the sympathetic outflow to that part of the face or the arm. And what is the evidence that those are helpful? Well, Wu and Opstelten studied this, or did a review in essence of it, and found that these treatments are widely used to help reduce the pain associated with postherpetic neuralgia. However, there was a lack of randomization in many of them and controlled. And I think it just goes back to my point before. I know that I'm going to sort of describe studies that are probably a little weak. However, I think it's added to our knowledge base, and nevertheless the injections can be helpful. So the reports primarily suggest that the sympathetic nerve blocks can provide really considerable relief, again, in the acute phase, acute herpes zoster versus later on when they develop postherpetic neuralgia. It may be short-lived, but it could be worthwhile strategy and often is, because a lot of these patients fail other treatments, save the pharmacologic treatments. The real key here, I think, to keep in mind is that what's interesting is that the injections can, if they reduce pain, can reduce the incidence of postherpetic neuralgia, because the severity of the pain of postherpetic neuralgia is linked to an increased risk of developing, let me say that again, the severity of pain associated with acute herpes zoster is linked to an increased risk of developing postherpetic neuralgia. So if you can reduce the pain earlier via pharmacotherapies or procedures, it's of benefit. This is how we do this injection. It's called a stellate ganglion block, and it's a blockade of the sympathetic outflow to the face, the head, the upper arm, for example, and the chest. It can be done at the bedside. It can be done under X-ray guidance. And essentially, if you're doing it at the bedside, patients are lying on their back, and you're palpating the cricoid cartilage and moving laterally. away from the big bad vessels here, the jugular, the internal jugular vein and the carotid artery, and you want to stay away from the trachea. So essentially you're inserting a needle to the transverse process of around C6, and then if you're doing it at the bedside, then you're just injecting with a lot of aspiration to make sure you're not injecting into a blood vessel of local anesthetics. On the right, this is what it looks like. These are the spinous processes here, and it's hard to see this, but the transverse process of, say, C6 is here. So what we're doing is injecting dye to indicate inferior spread, and then after that, we'll inject local anesthetics, sometimes some steroid. This is a sympathetic block called a lumbar sympathetic block. This is done for patients who might have pain in the lower extremity, for example. And again, typically done under X-ray guidance. It's on the left demonstrating probably around L3, L2, L3. This is the front, this is the back. They're on their belly. We're inserting a needle fairly long, about a 7-inch, maybe 22 gauge or 25 gauge spinal needle to the anterolateral aspect of the vertebral body. And once we're there, we inject contrast to ensure that we're in the correct area anatomically, and then after that, inject local anesthetics, maybe some steroid. This is just demonstrating the difference in, we're measuring temperature when we do these blocks, and we're expecting a temperature rise because we're blocking the sympathetics, and then you would expect vasodilatation. So in order to confirm that we've done the block in part correctly, we measure temperature. And this is just demonstrating one foot that's warm and the other foot that's cold after the block. This is one more block I wanted to talk about called the ganglion impar block. The ganglion impar is the terminal end of the sympathetic chain, and it's way down here on the left. It's maybe hard to see a little bit of this, but you see the sacrum and you see the coccyx here, and essentially we're inserting a needle, maybe 3.5-inch, 25 gauge, 22 gauge needle through a ligament, the anacoccygeal ligament, into this retrocecal space, and this is what we're doing under fluoroscopy, and you can see some dye spread here, and that's confirming that we're where we want to be and not somewhere else, for example, in the colon or the cecum. So, after this, we'll inject local anesthetic and maybe a little steroid, about 6 cc's or so, primarily of local anesthetic. Neuromodulation. Neuromodulation for neuropathic pain has been studied and can be useful. And neuromodulation essentially means either electrical stimulators or drug pumps. And either with respect to the stimulator, we're delivering small doses of electricity in a certain area of the spinal cord to help block painful sensation. The drugs would be something similar, via, say, a catheter, intrathecal catheter, that you're injecting to help relieve pain. These are the implantable pumps. On the left is demonstrated an intrathecal pump. It's a pain pump that might contain morphine. It might contain dilaudid or local anesthetic. This is implanted into a person, and this is the tubing that you thread to the spinal cord, and this is what delivers the medication, say the morphine or the bupivacaine, to the spinal cord. On the right represents a spinal cord stimulator. This is implanted as well. This is a receiver, and these are the wires, the leads they're called, that are implanted in the epidural space that then stimulate the spinal cord and provide paresthesias in essence and help block pain. Well, with respect to spinal cord stimulation and studies on PHN, there are mixed results in treating postherpetic neuralgia. In essence, it is an indication for postherpetic neuralgia after everything else has failed. And there are a couple of studies I've listed here. Sample size is a bit small in both of them, but in both of them, they do indicate that patients reported fairly significant relief. What about complex regional pain syndrome? This is the next and last condition I like to describe with respect to neuropathic pain. This is called, it really was renamed complex regional pain syndrome. In the past, it was called RSD. And it seems like a lot of people, patients and physicians, still refer to it as reflex sympathetic dystrophy, or RSD. It predominates in women. The age range is, sort of early adulthood. We think it's caused, by some type of injury. It could be a minor injury, it could be a fracture, a sprain, could be stunt. We see this in patients who've had surgery, for example, crush injuries, or even spontaneously. Typically, the pain is intense, it's burning, it's achy, and it's often in an extremity, an arm or a leg. There are sensory deficits associated with it, and what we see too is a lot of the clinical manifestations tend to be sort of swelling, color changes, temperature changes, decreased range of motion, weakness, hair changes. And this is an example of that. So these are fairly severe cases of this disorder. On the left, I think you saw this before. This is a woman who has CRPS of her left upper extremity. You can definitely see the swelling here. And of course, here it's hard to miss the edema and the erythema in the foot. There are significant toenail changes here as well, and reports of an enhanced sweating sensation. So she feels like the leg on the right sweats abnormally and sweats much more than the leg on the left. What's the evidence for injections, for interventional strategies to help treat this? Well, there are 3 typical injections we use: sympathetic blocks, spinal cord stimulation, and those intraspinal, those pain pumps, using baclofen or morphine. With respect to the sympathetic blocks are used frequently to try to help treat this disease process. And the quality of the literature on this is relatively weak. However, I have to say that, in seeing a lot of these patients, the sympathetic blocks, similar to the ones I described before, the stellate ganglion blocks in the neck and the lumbar sympathetic blocks for the leg, can be quite helpful, especially in allowing these patients to participate in physical therapy and occupational therapy, so they can strengthen, stretch that extremity. Most of these patients will not move the leg or the arm because it hurts so much. So if you can provide some type of reduction in pain via medications orally or some of these sympathetic blocks, it's worth it because their level of disability will decrease. Spinal cord stimulation can also be used to help treat this, and I have implanted the stimulators to help treat this disease processes in certain numbers of patients with a reasonable degree of success. And it's typically done in patients who are failing all other treatments. We've tried the blocks, we've tried the physical therapy, we've tried lots of different medicines, and still they feel like, gosh, the pain is just not adequately treated. So Kemmler studied this. It was a fairly significant article in 2000 where he studied patients who have CRPS and randomized them adequately. And basically, he studied patients who had, in whom the intervention, spinal cord stimulation plus physical therapy was used, or just physical therapy, and found that both, at 6 months and at 1 year, the pain was significantly reduced in the patients who had the spinal cord stimulator and participated in physical therapy. Unfortunately, there wasn't a significant improvement in functional status, and often that's an outcome that we look for in patients who have chronic pain. However, a lot of them reported an enhanced quality of life, and that's very meaningful in and of itself. This is just a slide on another study that was done that indicated that spinal cord stimulation was helpful in the treatment of complex regional pain syndrome. Patients reported decreased pain, decrease in disability, their functional status improved, and what they took in terms of opioid reduced as well. I feel like the opioids can be quite helpful, and they often are, along with the other adjuvants. However, they are sometimes fraught with side effects, so we feel like, gosh, if we can provide some type of interventional strategy that can reduce their pain to the point where they can reduce some of the medications that may be providing side effects, then that's a worthwhile goal. Does spinal cord stimulation, does the effect of that change over time? Unfortunately, it does, and not only in these patients who have postherpetic neuralgia or CRPS, but in other patients in whom we implant these devices. We don't really know why it happens, but there have been a couple of studies that have indicated that, say, somewhere between 3 and 4 years, patients start reporting a decrease or a decrement in their level of pain relief. I would say that a lot of these patients would say that even though the pain is not as well treated anymore, it was overall still useful in terms of providing them some enhanced quality of life for 3 years, for 4 years, whatever that was, because they had really no quality of life beforehand. What I'll just say about intrathecal systems, that is the pain pumps in terms of treating CRPS, is that there are case reports that report that morphine can be helpful. Also, that baclofen can be helpful, especially in patients who have dystonia related to complex regional pain syndrome. But the role of other agents that are used, like clonidine and ziconotide opioids, for example, aren't particularly clear. So we would do this rarely, and it's only if everything else has failed. So overall, I feel like really the ideal way to help treat neuropathic pain and chronic pain in general is an overlap of various different modalities. So, the pharmacologic treatments are especially helpful. as well as some of the interventional procedural approaches that I described today. Complementary medicine, for example, acupuncture is helpful, as well as the psychological measures, behavioral therapy to combat a lot of the associated depression and anxiety related to chronic pain, because it can, and neuropathic pain, because it simply can change your life, and it's an insidious process. Well, thank you very much for your time.